Okay, so we're going to go over some sympathomimetic medications, and these are some of the more common ones you will give in a cardiac situation. They're many hear them called vasopressors or something like that, but there's several different ones of them. Now, there are some that we use. Usually epi and dopamine are going to be your more common ones in the pre-hospital setting, but it is important to know and have a general understanding of some of the other ones as well. Now, just some background. Catecholamines are what's going to stimulate that receptor site within the sympathetic nervous system, right? Activate that fight or flight kind of thing. Right, it's going to do a group of things that we all should recognize, and we'll get to that in just a second. Your sympathomimetics are going to be just a synthetic chemical that's going to mimic that catecholamine response. All right, so this would be more like your amphetamines, phenylephrine, cocaine, things like that. Now, with your sympathomimetics, oftentimes they will actually have a longer duration than catecholamines. Sometimes that's a good thing, sometimes that's a bad thing, just depending on what exactly you're trying to achieve and how stable your patient is. Now, we remember, if you don't remember, then go back and watch the alpha and beta receptor sites in the nervous system stuff. There should be a link to that video in the module 2 as well. But remember that your alpha adrenergic receptors don't have really much of effect on your heart, but they're going to cause vasoconstriction of the systemic blood vessels, and they're going to cause some mild bronchoconstriction of your lungs. So alpha is going to constrict most of the time. Now, your alpha 2 is going to inhibit the release of norepinephrine, but we're not super concerned about that at this point in time. Your beta 1, one heart, is going to increase your heart rate, increase your contractile force, and increase your automaticity. And beta 2 is going to vasodilate within the vessels, and it's going to bronchodilate within the lungs. So it's going to be a dilator, essentially. Now, when we are talking about our alphas and our betas, all right, we often forget about the dopaminergic, and we don't spend as much time on those, but we will hit on those a little bit here. And so what we're looking at, all these different medications, are adrenergic receptors, or activate the adrenergic receptors, and we're looking what are they specific for. And specific just means, do they hone in on this one particular receptor site, or do they work across multiple receptor sites? For instance, if something is an alpha and a beta receptor, for instance, epinephrine has some alpha 1, beta 1, and beta 2 receptors in there, or selectivity there, so it's going to cause some vasoconstriction. We utilize that for anaphylaxis. It's going to have some beta 1 properties, so it's going to increase the heart rate and contractile force. We're going to utilize that in cardiac arrest. And beta 2, it's going to cause some bronchodilation, so we utilize that in our asthmatic or COPD patients. So depending on what it is specific to, it may kind of change what you use it for and what circumstances you may use it for. So some other just quick background stuff. As far as your alpha adrenergic drugs, norepinephrine is going to be your kind of prototype for the alpha class. And what this is this going, the biggest thing is the most important clinical effect, if you will, is going to be that it's going to contract smooth muscles. So this is going to vasoconstrict most of your blood vessels, including your sphincter muscles in the GI tract. So when you see your fight or flight, you know, we talk about the blood kind of rerouting or diverting away from the GI tract. This is how it does that. So it's inhibited by this norepinephrine. It's going to cause a sphincter contraction, which is going to divert the blood, and it's going to inhibit the movement of the intestinal contents, so it's not moving along and not burning that energy. Right? It's going to slow down the urinary output process. It's going to restrict the passage of urine, which means, you know, if you're trying to actively fight for your life or run away, you don't need to be worried about having to urinate and having to go pee. So sometimes if you ever notice, like, you get really scared, like I find if I'm running roller coasters, they scare me. I enjoy it, but they scare me. I find that sometimes, you know, like you may have to pee in line, but then you get on it and it's like the urge is just gone. And then dilation of the pupils of the eyes, so you can see a little bit better during this particular time. Now, usually the alpha drugs are going to be given IV infusion when the patient is hypotensive. All right, they may give it after surgery to increase blood flow or blood pressure, to maintain circulation. Some alpha drugs are actually given like a nasal mist or a pill, and what this is going to do is it's going to actually kind of decongest the nasal area. Can't speak right now. Phenylephrine is a fairly common one you can get over the counter at the pharmacy or wherever. Some other ones may be used in ophthalmology to dilate pupils, things like that. Some of them, like amphetamines, actually can produce a central effect and suppress appetite, so they may be used for that instance. Now, your biggest adverse effect overall of your alpha adrenergic drugs is going to be excessive vasoconstriction of blood vessels, which means it can lead to a hypertension or hypertensive crisis, or even like heart palpitations or something like this. So in certain patients, this could lead to a cerebral hemorrhage or cardiac arrhythmias or something like that. So if you're given an alpha drug, you need to make sure that you are monitoring that patient very carefully. Okay? If you are giving it IV, which is how you're pretty much going to be giving it, you need to make sure that it's not infiltrated. Okay? If it has infiltration, it will cause really severe vasoconstriction of the blood vessels supplying the skin, which can lead to death of the skin cell and ultimately gangrene. As far as your betas, all right, now betas, most betas are going to be selective. Most beta adrenergics are going to be selective to just beta stuff, with the exception of epi. Right, epi does have a few alpha effects, but most of them are going to be selective for either beta 1, which is going to be dealing with the heart, or beta 2, which is dealing with bronchodilation. Isoproterenol is one of the most potent beta adrenergics, but when it works really well for bronchodilation, but it also is going to work really well on the heart. So that action there is actually a disadvantage in using it for bronchodilation in asthma or allergies or something, because it'll overstimulate the heart, so their heart will start running away with them, and we don't want to do that. Right? So because of this dual stimulation, a while back, I don't remember how while back, a long time ago, they did some research and actually found some of the selective beta-2 drugs, and those are now the more common bronchodilators like albuterol. All right. Now, there are beta-2 receptors in the uterine smooth muscle, and stimulation of the beta-2 receptors within the uterus actually is going to relax smooth muscle and inhibits uterine contractions, which is why terbutaline is, it's a bronchodilator, but it also is a tocolytic in certain circumstances. Now, your adverse effects generally here, they can produce a central nervous system stimulation, which can lead to like a restlessness, tremors, shaking, anxiety, that kind of stuff. But the most adverse effect, most of them is going to be overstimulation of heart, palpitations, or cardiac arrhythmias. Now, when you get into a higher than normal or higher than therapeutic dosage, even the selective beta-2 drugs can also stimulate the cardiac beta-1 receptors, which can overstimulate the heart. All right. As far as using the beta-2 drugs to stop preterm labor, being a tocolytic, it's a weighing system. It's not something you're just going to do willy-nilly, because there are some very serious potential cardiovascular effects and complications that can affect both the fetus and the mother. So you want to monitor very, very carefully there. All right, so moving on to some of these specific drugs. So if I can make this thing work. So epinephrine is a sympathetic agonist. It's a naturally occurring catecholamine. We have it in our body. It's very potent. It's a potent alpha and beta adrenergic or stimulant. But it does focus primarily, not focus, but it's much stronger effect on the beta receptors. All right. Increased heart rate, increased cardiac contractile force, increased electrical activity, increased systemic vascular resistance, that's that alpha property kicking in, increased blood pressure, ditto, and increased automaticity. All right. It also causes some slight bronchodilation as well. So it hits all of the main peaks there for your alphas and your betas. The onset's relatively quick. Peak effects are usually about 5 minutes or less, and the duration is going to be 5 to 10 minutes, and the half-life's about 5 minutes. So for this, 90 seconds after administration, they're usually showing their effects, and then it's going to wear off over the next several. This is why we have to give multiple doses of epinephrine in cardiac arrest, and potentially multiple doses in an anaphylaxis situation, just depending on what that particular situation is and how severe the anaphylaxis is. So your indications: cardiac arrest, asystole, VFib, PEA, pulseless ventricular tachycardia, anaphylaxis, severe reactive airway disease, which essentially is asthma. As far as your contraindications, okay, we don't use the 1 to 10,000 in patients who are not requiring CPR. All right, if they're not actively trying to die or dead, then they don't get the 1 to 10,000. For your simple allergic reactions in asthma, we're going to use the 1 to 1,000 dilution, and we're going to give it either sub-Q or IM. Now, a lot of books still say sub-Q, but for the most part, most injections are going towards IM just because it's going to be a faster absorption through the large muscle groups versus subcutaneously, so we're going to get that reaction that we want to happen a little bit faster and a little bit more reliably than the sub-Q on that. So our dose depends on why we're giving it. For an adult cardiac arrest, 1 milligram of 1 to 10,000 IV/IO every 3 to 5 minutes. 2 to 2.5 times the IV dose if you're giving it down the tube. So that would be 2 to 2.5 milligrams, but in your standard concentration, that means you're giving 20 to 25, 30 milliliters of volume in the lung. So that's not recommended as your first line. That's kind of like a backup, last-ditch Hail Mary. For your pediatric cardiac arrest, the first dose is going to be 0.01 milligrams per kilogram of the 1 to 10,000, and then your subsequent dose is going to be 0.1 milligrams per kilogram of, error there. All right, so I just realized there's an error there. All your subsequent doses, I put my zeros in the wrong spot. Your subsequent doses will be the same as your first dose, the 0.01 milligrams per kilogram of 1 to 10,000. 1 to 10,000, not 1 to 1,000, okay? I'll have to correct that and fix that. But for now, 1 to 10,000. All right. For your severe anaphylaxis or asthma, for an adult, it's going to be 0.3 to 0.5 milligrams of 1 to 1,000 IM and 0.3 of 1 to 10,000 IV if it is refractory to that initial dose there. And you can repeat this every 5 to 15 minutes. For your severe allergic reactions or asthma in a pediatric, 0.01 milligrams per kilogram of 1 to 10,000 IV or 0.01 milligrams per kilogram of 1 to 1,000 IM. And we're going to repeat that every 5 to 15 minutes as needed. So our side effects, palpitations, anxiety, tremulousness, that's like tremors, headaches, dizziness, all this fun stuff, right? Increased myocardial oxygen demand. For a young, relatively healthy person, that increased oxygen demand, probably a negligent amount, not a big deal. But for somebody who is already cardiovascular compromised, it could be a substantial amount. So that's something to keep in mind there. All right, precautions should be protected from light. A lot of drugs are actually like this. And this is why if you ever look at a multi-dose vial or like a pre-filled ampule or something like that, they actually come in a darkened glass jar or vial, and that's to protect it from the light because the light will actually deactivate it. All right, they can be deactivated by alkaline solutions such as sodium bicarb. What do we often give after a code's been going on for a little while? Sodium bicarb. And then what do we give right after that? Epinephrine, right? Or before it. So just keep that in mind that if you are giving this, you want to make sure you're flushing really well, and ideally you're going to want to have 2 IV lines established because bicarb does not play well with pretty much anything else. Calcium chloride, calcium gluconate, pretty much all your sympathomimetics. None of them get along with sodium bicarb. So if you have a separate line, that would be ideal. Not always feasible, but ideal. Now, your interactions, all right? With this, the effects can be intensified if they are taking antidepressants. Now, if they're in cardiac arrest, are we going to be as concerned about this? No. But is this something to think about in a anaphylaxis and you give it? That means they may have more risk of palpitations, more anxiety, or headache, or nausea, or something like that. It's just more likelihood that it may occur there. Now, moving on to your norepinephrine or your Levophed. You ever heard of Levophed, leave them dead? This is like the last-ditch effort. It is a very, very potent alpha adrenergic catecholamine. It does have some beta receptor activity, but much more so on the alphas. So it is going to increase your blood pressure in your cardiogenic shock or other hypotensive emergencies. Okay, it will constrict the renal and the mesenteric blood vessels, and that's working on the dopaminergic side of it. But it's usually reserved for those emergencies in which dopamine may not be effective, because dopamine usually will work with less severe side effects in most situations. So basically, they're usually going to try dopamine first, then revert back and go with a Levophed if nothing else has worked. So your onset is going to be pretty much immediate. As soon as it gets in there, it's doing its thing. Peak effects are less than a minute, so very fast. Duration's 1 to 2 minutes, and the half-life is 3 minutes. So what does this mean? It means this is going to be an infusion. I mean, this is going to have to be something that's given continuously in order to make it keep having its thing, do what it's supposed to be doing. So your indications could be hypotension, usually systolic, less than 70 or so. That is refractory to other sympathomimetics, because that therapeutic index on this, that window of working in problems is a little smaller than some of your other ones. All right, that hypotension has to be not related to a hypovolemia. And what this means what this means is that basically if it's a volume problem and not a container size problem, you need to fix the volume first. You need to address that volume problem before you go for anything else, okay? Because if that volume doesn't get fixed, you can tighten up the container all you want. It's not going to fix the problem. All right, it's used for neurogenic shock, which is a container size issue, and it has actually become kind of a first-line agent for septic shock, which we know septic shock, sepsis can move very, very rapidly, so that's why this is more the first line for it, because they are so in such a precarious situation medically. Now, contraindications. If they are hypotensive from hypovolemia, if they have lost volume for whatever reason, you don't need to give this to them. You're not going to make them better. You're going to hurt them more. You've got to fix that volume problem first. All right. As far as our dosages, typically your dose is going to be, recommended by AHA, it's going to be 0.1 to 0.5 micrograms per minute. 0.5 to 1 micrograms per minute, maximum of 30 micrograms per minute. It may need to go higher, but we're probably not going to be taking it any higher than that. So your easiest way to get a good dilution, a good concentration here, so you're going to take 8 milligrams, draw it up, and you're going to put it in a 500 ml bag of D5W, and this is going to give you a concentration of 16 micrograms per milliliter. All right. Or you can put 4 milligrams into 50 mLs of D5W and get that same concentration of 16 micrograms per milliliter. Okay, you need it to be extremely diluted because it is so absolutely potent. This is going to be one that you will have to piggyback into an already established IV line and control and give it with a controlled pump. This is not going to be one in the field that we can easily just count the drops and roll with it. It needs a pump in order to give this medication. Now, your interactions can be deactivated by alkaline solutions. Like I said, a lot of the sympathomimetics can. And if you give this in addition to beta blockers, which is a fairly common home medication for blood pressure and things like that, it can give them significant high blood pressure, like to the point where you might kill them. So we don't want to do that. So think about that. Side effects: anxiety, tremulousness, headache, dizziness, reflex bradycardia. Basically, that's your body trying to make up for the increase in the vasoconstriction there. It's like, oh crap, what's going on? Let me adjust here. And increased myocardial oxygen demand. Precautions: measure your blood pressure every 5 to 10 minutes. Well, honestly, should you even wait 5 to 10 minutes? You're probably going to do it pretty routinely. It should be like an automatic thing to make sure that our blood pressure is not creeping up, because it will creep up, and it will creep up very, very quickly on these patients. Fluid administration should already be given or initiated before you administer the Levophed. If it extravasates, like I said earlier with the alphas, it can cause that local tissue necrosis, so you really want to make sure that your IV is patent. It may increase the myocardial oxygen demand, and so you're going to want to use it with caution in somebody who has any kind of cardiac ischemia or cardiovascular history there. Now, your next one, your phenylephrine. All right, it's also called neosynephrine. I may have probably slaughtered that name, but the phenylephrine I'm good with. I say that one. All right, this is a synthetic catecholamine, and it's primarily going to be an alpha alginergic receptor site, and it doesn't really do a whole lot for the betas. So it's mainly going to act on the vascular smooth muscle in the heart and the lungs. So it's going to increase that peripheral vascular resistance, which is going to increase your blood pressure. And also, topically, like a nose spray or something, it can be used on the mucosal membranes, which is going to cause vasoconstriction prior to nasotracheal intubation. If you've ever taken a nasal decongestant, this is a fairly common ingredient in a lot of those as well. And it will actually sometimes give you a headache if you take too much of it, because it constricts so tightly. Your onset's pretty much immediate when given IV. Peak effects less than a minute, durations 15 to 20 minutes, half-life's only about 2 minutes. So it's a fairly rapid, short-acting medication there. Your indications: non-hypovolemic hypotension, usually systolic blood pressure less than 70, MAP less than 65. And this is where you have peripheral vascular resistance that's reduced due to spinal shock, septic shock, something like that. And it also may be used topically prior to nasal intubation to minimize any bleeding that can occur. Your contraindications: we do not use it to increase the blood pressure in the cardiogenic shock, which makes perfect sense because if we increase that myocardial oxygen demand in a heart that's already failing, we're just going to make it fail even faster, and it's going to increase that systemic vascular resistance, which means the heart has to work faster, and now it needs more oxygen. So you've just punched it while it's down, basically kicked it while it's down. All right, so you're going to use some other sympathomimetics like dopamine first. Now your dosage, usual dosage is 100 to 180 micrograms per minute over IV. All right, which is, usually about half a milligram or half a microgram per kilogram per minute. Once you get that blood pressure stabilized and it's at a good level, we're going to just taper it off to 40 to 60 micrograms per minute to maintain. This also will have to be a piggyback IV line, right, going into your saline or something like that. Side effects, same thing as all of your other sympathomimetics here. Precautions, make sure you've got a patent IV because extravasation will cause that tissue to rot and fall off essentially. All right, interactions is deactivated by sodium bicarbonate, surprise, surprise. You also want to be very careful if you suspect that your patient has a DIG toxicity because it can aggravate and worsen your tachyarrhythmias that can occur with that. Now your dopamine is an interesting one. It's an alpha and a beta and a dopaminergic adrenergic receptor sites. Try saying that 5 times fast. All right, its effects on the alphas are going to be dose dependent, but it will cause peripheral vasoconstriction. It will act on your alphas and your betas like the epi and norepinephrine and increase the blood pressure, and it will cause that positive inotropic effect on the heart, but it doesn't do the same chronotropic effects as the other agencies. It also does not increase the myocardial oxygen demand as much as epinephrine or isoproterenol do. So kind of interesting little thing there. At your low doses, which is going to be like 0.5 to 2 micrograms per kilogram per minute, it's actually going to stimulate those dopaminergic receptor sites in the renal and the mesentery artery. So this is going to increase blood flow, renal blood flow. At your moderate, which is like your 2 to 10 micrograms per kilogram per minute, dopamine is going to stimulate your beta 1, which is going to increase your contractility, increase your cardiac output. All right. Increase in cardiac output and renal blood flow during shock are super, super important, which is why you typically see your pre-hospital dosage for dopamine being within that range, that 2 to 10 micrograms per kilogram per minute. Right, now, at your higher dosages, 10 to 20 micrograms per kilogram per minute, that's where we get the alpha effects and we start to have the vasoconstriction. All right, dopamine is going to be given by continuous IV, and those effects, as you can see, the half-life is like 2 minutes here. So those effects are going to disappear very quickly once that infusion is stopped, as will the adverse effects once you slow down that medication. So your indications here, oops, too far. Your indication, a hemodynamically significant, meaning they're swimming the crapper, hypotension with a systolic blood pressure 70 to 100 or less, bad map, not resulting from hypovolemia. Once again, hypovolemia. If the problem is hypovolemia, we have to fix the contents. We have to put more contents in. We need blood products. We need the fluids. We need whatever to replace whatever is missing. We give this for cardiogenic shock because, unlike the other ones, it does not substantially increase myocardial oxygen demand like the others do. Right? It may also be used to increase your heart rate in patients who are resistant to atropine. So for refractory to atropine for symptomatic bradycardia, dopamine may be a good option there. All right, your contraindications. It should not be the sole agent of management of hypovolemic shock unless fluid resuscitation is well underway. We don't want to give them tons and tons of fluids. We know this. We know if they're losing blood, we need to replace the blood, but we have to get some kind of fluid in them. All right, and then it should not be used in patients with a known, I'm going to try it, pheochromocytoma, some kind of tumor of the adrenal gland. Until I started working and putting all this stuff together, had never heard of that. So, but if you know they have it, and if the patient knows they have it, you may want to talk to your med control before you give it to them. I really don't know why you're not supposed to give it to them. I'm going to have to go look it up, though, because I can't remember. So your dosage. Your concentration typically is going to be 1,600 micrograms per milliliter, which is you're going to take 800 milligrams and dilute it in 500 mLs of D5W or normal saline, and you are going to, or you can take 400 and dilute it in 250, and that will still give you that same concentration of 1,600 micrograms per milliliter. And then we're going to start our infusion depending on what you need it to go with. If you're wanting just to improve renal blood flow, 2 micrograms per minute. If you're wanting to improve the cardiac output and some a little bit mild vasoconstriction, you may look at 2 to 10. And if you are wanting some substantial vasoconstriction, then you may want to look at 10 to 20 or so. And then you're always going to titrate to exactly what you need to do. So we're going to titrate to achieve what we want with that patient, which in our case, pre-hospital, usually is going to be improved perfusion, improved blood pressure, cardiac output. Side effects, all the same stuff as the rest of your sympathomimetics. So have them on the monitor, reassess the patient. Precautions, it can induce or worsen supraventricular and ventricular arrhythmias. So if they've got a funky little beat, it can turn into a lot of funky little beats, which is not a good thing. If you are going past that top end, that 20 mics per kilogram per minute dose of dopamine, it's going to act like norepinephrine. So you're going to have some really, really potent vasoconstriction, and then you're going to have potential for hypertensive crisis, and we don't want that. Once again, it can be deactivated by alkaline solutions like bicarb. If they're taking MAOIs, which those don't play well with anything either, so you may have to alter or reduce your dosage. And if the patient is also taking phenytoin or Dilantin, usually for seizures, then it can actually cause hypotension when given in addition to that. Okay. Now, dobutamine or Debutrex is a synthetic catecholamine, and it's primarily going to act on your beta 1s, but it's not as potent as your isoproterenol. Okay, so it's going to increase the force of your systolic contraction, that positive inotropic effect, with little chronotropic. So it's not going to increase the rate so much, just the force. And they're going to use this in the management of CHF when we're not trying to increase the rate, we're just trying to increase the effectiveness of that heartbeat. The onset's pretty fast, duration, it depends. Half-life's pretty quick too, 2 minutes. So this is going to kind of fade out pretty fast as well. Indications, short-term management, okay, not long-term drug. Short-term management of CHF when we want to increase cardiac output, but we don't want to increase rate. All right, if you want a rate increase as well, there are other options that work better for both. For contraindications, don't use it as a sole agent for hypovolemic shock unless fluid resuscitation is well underway. Same thing. Got to fix the content problem first. And if you're trying to increase cardiac output in a severe emergency like cardiogenic shock or something like that, then dopamine is preferred over dobutamine because that's going to have more across-the-board actions that would be desirable. Our dosage, we're going to take 250 milligrams. They're going to dilute it in 500 milliliters or 1 liter of D5W, and it's going to be given between 2 and 20 micrograms per kilogram per minute as well. Precautions. It can cause tachycardia. An increase in the systolic blood pressure are somewhat common. And if you do have that increase in heart rate, then you can exacerbate any kind of underlying ischemia, and it can cause PVCs and other funky little rhythms. Side effects are the same as all of the other sympathomimetics. Right, your interactions, once again, if they're taking beta blockers, may not work as well. It may kind of work against it because it's going to activate on those beta receptor sites, right? That makes sense. If they are taking a tricyclic antidepressant, trophanil is the one that comes to mind, and amitriptyline, I think, are they at risk or higher risk for hypertension with this medication as well.